All right, and we're back after the briefest of breaks with Rayan to introduce our next speaker, Dr. Gifty Asare. Rayan, take it away.
So thank you so much for coming, Gifty Asare. We are so pleased that you're able to join us. Our next session is going to be talking around cross-sectoral solutions, supporting survivors of gender-based violence, related trauma, brain injury through survivor-led program. Just a little bit about Gifty Asare. She's a Ghanaian-Canadian researcher from Montreal and is currently the Director of Research and Community Impact at Women at the Centre, which is a nonprofit by and for survivors of gender-based violence. So without further ado, I'm going to ask you to share your screen and share your wealth of information. I know the work that you've been doing in research on this issue. So thank you so much. And again, just a reminder, if anybody has questions, to post those in the Q&A box, and we will be posting also any links in the chat box as we go. So thank you.
All right. Thank you so much, Rhian, and thank you everyone for being here today. I guess the introductions have been done, so I can jump right in. So today I'll be talking about Cross-Sectoral Solutions. This was a 3-year funded project by the Public Health Agency of Canada. And as Rhian shared, it's to look at how we can support survivors of gender-based violence with a traumatic brain injury, and doing that with survivors at the center. So before we begin, I'm just going to share a land love, land reflection, land acknowledgement, solidarity statement. At Women at the Center, we shared how this is a survivor-led organization that is pan-Canadian. And although we are pan-Canadian, we do operate largely remotely. However, a lot of us are based in Ontario. As what we know as Ontario, I personally am in Montreal, Georgiake. And so Women at the Centre acknowledges that the land on which we operate on is territory of the Huron-Wendat, the Anishinaabe Nation, the Haudenosaunee Confederacy, Métis, Inuit, and the Mississaugas of the Credit, and that these lands were taken without consent. And so today this land is still home to many First Nations and Indigenous people from across Turtle Island. We also want to acknowledge that that there are those who are here involuntarily as part of the transatlantic slave trade. And so an inherent part of our work is taking action to disrupt, to dismantle the embedded impacts of colonialism, racial capitalism, imperialism, and patriarchy. And so today and always we stand in solidarity with Indigenous women, girls, trans, gender diverse, and two-spirit people. And we recognize that the work we do must be rooted in respect for the original caretakers of this land. So today, this is a very simplistic agenda, and we have a little bit of time, but essentially want to talk about the intersection of gender-based violence and brain injury, and then a 20-week pilot program that is Cross-Sectoral Solutions, and then the key findings and recommendations from this project. And I know that this is an event looking at elder abuse and the prevention of elder abuse and dementia. And taking a different approach here with regards to this project. Its primary focus or aim wasn't specific to the elder community or the older adult community. However, it does tell us a lot about how to have an effective program for survivors living at this intersection. And it also tells us a lot about kind of the key activities and supports and services that will really support a survivor and an individual across the lifespan to ensure healthy aging. And so that's a little bit of the approach that I'll be taking today. And so, without further ado, I know that folks here probably most likely know about intimate partner violence and traumatic brain injury. But I want to highlight the complex nature that includes cognitive, physical, psychological, emotional, even financial challenges that are then further complicated by socially derived barriers to care and well being, and how traumatic brain injury also does the same. And so looking at the intersection of the two once they kind of come together. And so, why does the intersection of intimate partner violence and traumatic brain injury matter? Well, prior to COVID-19, intimate partner violence was alarmingly common in Canada, impacting 1 in 3 women throughout their lives. And as the governments advised people to stay at home, reports of IPV in Canada surged by 20%. And the severity of the violence escalated, leading to what we now know is a parallel pandemic. And so, Women at the Center specifically didn't only see an increase in the number of cases of gender-based violence, but also in escalation of the frequency and the severity of the violence. So, for example, compared to pre-pandemic numbers, crisis calls increased by over 300%. And then the number of risk assessments and safety plans conducted with gender-based violence survivors increased by over 900%. And 51% of these cases were assessed or identified as high risk. And so that's with that, we had almost 50% of the survivors were disclosing that they had been strangled by their aggressors in the last year. And strangulation has been identified as one of the biggest factors for physical harm and death, because the abuser literally holds the victim's lives between their hands. And so that calls us into action, quite frankly. And note point 3 here, that brain injury among survivors of IPV is a critical issue because 75 to 92% of women likely experience a brain injury from the facial, head, and neck injuries that they sustain. Also wanted to take some time to advocate and to look at the language that is being used throughout the presentation and this event. So Women at the Center advocates that language is a powerful tool. It not only shapes the experience of violence, but also the profound impact of how people in communities are represented and thereby treated. So we advocate for the use of gender-based violence in place of intimate partner violence to encompass the various forms of violence that may not align with the restrictive ways in which IPV is currently conceptualized, not only within policy, but within practice as well. And you'll note that there is still language of IPV being used because in the literature, in research, in the statistics being referenced, those were the terms that were exactly referenced. And so to ensure that our citations are accurate, that language persists there. However, making the shift is important because we know that there are survivors of sexual violence and of human trafficking, which are all individuals that we serve within our organization. And they've shared that oftentimes they don't identify as being in an intimate or a romantic relationship with their aggressors. And so consequently, this impacts their access to much needed services and supports. The other kind of view or perspective that's worth noting as well is that language can sometimes present barriers to access. And so thinking about older adults, we have another project called Truth and Transformation that's looking at the experiences of Black people, Black women, girls, gender diverse, and trans folks across Canada, and looking at the racial inequities that are present. And in that study particularly, we noted that the language of intimate partner violence and gender-based violence didn't necessarily resonate with our older adults. Even the language of domestic violence was somewhat of a barrier. And so using language that was colloquially acceptable and culturally acceptable was very important. And so always kind of inviting folks to think about their use of language and how it can be accessible depending on the people, the communities that they are serving. And so we look at the impacts of gender-based violence and brain injury, and we note that there are all of these experiences across the different facets of humanity, really: mental, physical, emotional, social, and financial. And here I've just listed a few, but thinking about gender-based violence, we can see how a survivor might be hit, kicked, or shook, and how they might experience low motivation, fatigue, poor appetite and sleep, fear, anxiety, isolation, and how the social ramifications of that may be poor financial stability and independence, as well as some difficulties with childcare. We can then see how, for brain injury, the specific symptomology might look like difficulty expressing emotion, slow information processing, memory processing issues, problems with concentration and attention, coordination, as well as chronic pain. So we can see how we might have some unique and nuanced symptoms and experiences with regards to each of these events, but we can also see how they will intersect and have some social ramifications. And so, for example, this could lead to isolation, help-seeking behaviors, a loss of identity and self-esteem, and this could all be compounded and exacerbated if you have elevated rates of unemployment, poverty, homelessness, and thereby resulting in these substantial economic repercussions, such as a loss of income and productivity, and then, of course, the higher social and health-related support costs across the individual's network, and then across the nation. And so the impact of gender-based violence and brain injury is not only at the individual level, but we're really thinking about all the different networks with which there's an impact. And we're thinking about the individual, their support, their caregivers, their family, as well as their caregivers, peer navigators, service providers, and then beyond to kind of think more about the municipality, local costs, as well as governmental costs. And so, given the specific topic that we have today, or the specific emphasis on elders, I wanted to kind of highlight two areas that are critically impacted if you are a survivor living at the intersection of gender-based violence and brain injury, and thinking about how that could be compounded and the effects of that throughout the lifespan and then in aging. And so memory being one of them, a survivor may exhibit difficulty learning new ideas, forgetting information, losing or misplacing items, and then trouble scheduling. And some support strategies that have been found to be effective would be to provide summaries and recaps, to verify understanding as one is interacting with the individual, having memory aids. And so popular, at least among some of our survivors, are stickies, whether like the physical, like sticky notes, or even those on the desktop or computer, having checklists, reminders in the form of notification, emails, phone calls, and just increased interactions overall, and then specified locations for interaction so that there's an anchor that serves as a reminder for individuals as well. Another area is mood and emotion. And so survivors living at the intersection may exhibit abrupt mood changes, emotions not aligning with the situation, escalation of anger or irritability with small triggers, with difficulty de-escalating, symptoms of anxiety and or depression. And some of the support strategies would include monitoring the symptoms. And so maybe having a symptom diary or journaling, avoiding responding emotionally if you are the caregiver or a support person, recognizing triggers and offering alternative approaches, and then creating, implementing techniques of regulation, particularly mood and emotional regulation. Now, worth mentioning again that these are symptomologies and occurrences that we've observed with survivors living at this intersection, but you also might recognize that these are also experiences that you could see in older adults that have dementia or cognitive decline. And so noting that we can imagine how living at this intersection and then aging and having the compounded effects of dementia or cognitive decline could make this much more difficult to cope with. And so bringing that awareness about earlier on could support in being protective against what might be a worsening of these situations. It's also important to know that these support strategies are not only for the individual that are experiencing these symptoms, but really for the care network that's supporting an individual as well. So, for example, monitoring symptoms might seem straightforward, but of course, if you're the one experiencing it, it might not be as obvious. Journaling is almost counterintuitive to having to note take, which can be extremely taxing. And so thinking about supports and the individuals or the people that are going to support is also very much critical when trying to help individuals living at the intersection. And so I'll shift to talk about the project Cross-Sectoral Solutions and why it was named such. And so we really wanted to emphasize and center a holistic wraparound approach to this program. And I know that that's also words that were used just recently by Megan when in the presentation ahead of mine, but it is important and it is crucial. And we've also found it to be extremely effective. And so this particular program or pilot project had 21 interdisciplinary students. So these were students that were part of the services that we offered. And so we had occupational therapy students, we had speech language pathology students, we had some nursing students as well. So essentially across 10 programs and in 7 schools. And we had meetings with different individuals that had expertise in the areas of concern. And so we had a Stakeholder Advisory Committee, so that's the SAC. And so across the 3 years, we had 12 of those meetings. We also had WeSec, which is the Women at the Center Survivor Expert Collective. And so these are survivors that are living at the intersection of gender-based violence and brain injury. And they were instrumental throughout the program, not only in the initiation, but the development, the planning, and the accountability of the project. And then we had host site meetings. So we had 3 host sites across Canada. And these were organizations that were serving survivors that were living at the intersection in one way or another. And they also enabled us to ensure that we had representation, for example, having French and English, Francophone and Anglophone representation across the nation, and also other marginalized communities, including those who have disabilities, Indigenous, Black folks, so forth and so on. And so with all of these individuals a part of the project, we were able to have 46 unique partnerships to really ensure this cross-sectoral approach. And we had one pilot program that was launched last May to September. 25 survivors participated, and they were supported by 5 peer navigators. And so all in all, this project came to an end last month. Can't believe that was just yesterday. But essentially, we had 14 new knowledge mobilization events come out of it. One conference that we held in March, a 3-day conference held in March, as well as 17 new knowledge mobilization products. And that's a lot for me to just share and kind of regurgitate, but all of it can be found on the Women at the Center website. And we kind of link all of our resources and events there as well. So just to take folks a little bit through the project, the main research question was to see what the impact of an evidence-based trauma and violence-informed multi-sectoral pilot program would be on survivors living at the intersection of gender-based violence and brain injury. And we also had 2 other questions, which was to see the impact of this on service providers as well as on host sites. But for the purposes of this presentation, we'll focus on the impact on survivors. So it was a 20-week pilot program. We really wanted to create a blueprint of what works for critically needed supports, and we wanted to improve the health and well-being of survivors. We had 8 services. The evaluation consisted of 6 surveys and a focus group or interview. And as mentioned, this was to 25 survivors. Looking at the services, we offer 8 of them, and we like to call it, I guess, a service buffet, which I've now grown particularly fond of. But survivors could really pick and choose how they wanted to engage with the different services that were being offered. One-on-one peer counseling was offered on an ad hoc basis, and so as needed, participants would engage in the one-on-one peer counseling. Following that, the other services had a relatively fixed number and they had different start times during the 20 weeks. And so, for example, naturopathy was 4 pre-recorded sessions that survivors could engage in however they wanted to or whenever they wanted to. And then we had 32 psychotherapy sessions that were on specific days, and participants could kind of engage with those when they wanted to as well. As mentioned, we had 6 surveys, and so we had a pre and a post survey, and then 4 interim surveys. And during the surveys, we wanted to ascertain the demographics, but the health and symptomology of survivors throughout the weeks, how they engaged with the program, if they had gained any knowledge or skills, if their basic needs were being met with the peer navigation, and then whatever personal goals that they had and if they were reaching those personal goals. We also provided like survey supports, and so we had a dedicated staff member to support survivors throughout with regards to survey completion. It was in French and English. There was audio or video recorded responses if folks didn't want to necessarily like type in their responses, so forth and so on, and had essentially a near perfect survey response rate across the 6 surveys. And so who are the survivors that participated? So I'm going to kind of go through this visualization from right to left. And so we had 23 women, 1 Two-Spirit, and 1 odd-gendered individual. And if we look at the top donut, that tells us the ethnic background, mainly white survivors, but we also had a quarter of the survivors were Black, which is a decent representation, but still not quite representative of the current or realities when it comes to Black survivors in Canada. The same for Indigenous folks. We had 3 individuals, but not representative of the reality either, so still underrepresented in our sample here. And then other were mixed ethnicity with 1 South Asian individual. In terms of age, the majority of our survivors were between the ages of 25 and 45. And then we had a few between that 46 and 59, with 1 individual that was above 60 and then 1 under 24. And so, as mentioned, this was really looking more at a pilot program to really just gain insight on how best to support survivors. But given that it was a pilot, we have yet to look at it in different communities and specifically in different marginalized communities. Looking at the representation across the nation, most of them are coming from Ontario, with 18 of our survivors from there, 3 in Quebec, 2 in Alberta, 2 in BC, and then 1 in Northwest Territories. If we do the math, we realize that this is 26. And so we're over, but that's because 1 individual shared that they considered themselves to be both from Ontario and the Northwest Territories. And so we also inquired about survivors' income, and we saw that almost half made less than $20,000 a year. I think we can all agree, knowing the economic status of Canada at the moment and just how much the cost of living is, that is nowhere near enough to survive. And so looking at the 2025 federal poverty line in Canada and the projections that were made, essentially half of the survivors were below the poverty line. And so it comes to no that most of them were inquiring and advocating for themselves in terms of financial assistance. And so 68% were receiving additional financial assistance. And they shared kind of where this was coming from across Ontario, Quebec, and some of the other provinces. But what that looked like was either disability insurance, benefits and pension, disability benefits and pensions as well. And essentially seeing how like critical and important it was for this piece to be addressed as we went along the program. Next, we inquired about the brain injury and kind of trying to ascertain exactly how that was acquired, and also telling us a little bit more information about how it intersects with gender-based violence. And so 91% reported that gender-based violence was the root cause of their brain injury. And when we asked how the brain injury was sustained, we saw that 65% reported that it was sustained through a hit to the head, which is important to note because it definitely tells us what symptomology to highlight, and also what support tools and services might be helpful for that specific mechanism of sustaining an injury. Some of the other ways included being knocked out, a broken nose, a broken jaw, sex trafficking, smashing head into walls, a gun shooting, and more. We also see a large representation of strangulation as well as choking. And that's also very important because research is now, especially at the specific intersection, noting more and more implications of the loss of oxygen to the brain and the impact that that has, not only on one's immediate symptoms and experiences, but when it comes to aging, what that loss of oxygen means over time. And so noting that strangulation and choking together accounted for about half of the experiences was quite informative. Next, we asked about the frequency of the gender-based violence-related brain injury, and noted that essentially, once a survivor experienced a brain injury in the context of gender-based violence, chances are they were going to experience another. And so we have 8 individuals experience 1 to 3, and then 4 to 6, 7 to 9, 10 or more, many. A survivor reported sustaining as many as 50 occurrences, and another shared that they had lost count. And so very critical to intervene when an individual shares having experienced a brain injury in the context of gender-based violence, but also important to bring about that awareness because there are those that haven't really been in a supportive environment or in an environment that allows them to share that experience. Oftentimes, brain injury can be overlooked for physical symptoms that seem more pressing to caregivers or service providers or frontline workers. And so the brain injury might kind of take a back seat. But after noting not only the frequency, but also the ramifications that it has long term, we definitely note how important it is to kind of take a deeper look in this, not only research-wise, but definitely in the community as well. And so with regards to the programs offered, we looked at the participation and we saw that the most attendance was with peer counseling. This was no shock because, again, it was on an ad hoc basis, and survivors really enjoyed the bond and the relationship that they formed with their peer navigators. And we'll see soon in the qualitative results how that was expressed. And then the others, the average attendance across the programs was around 22%. And so to discuss the findings now in terms of health, we saw a slight increase in general health. These are all based on self-report measures. So a 4% increase. Mental health increased 34% across the 20 weeks. And on this slide, lot of information, but I'm just going to point folks to the blue and purple line here, which is what we just saw. So the 4% increase being the blue line, which is the overall health, and then the mental health that increased 34%. As those two increase, what we saw was an 11% decrease in the difficulty to complete task, which is the green line. And so across the weeks, essentially, survivors shared that it was easier to complete everyday tasks, easier to do tasks like cooking and cleaning, getting dressed, working on projects, and scheduling. And these are tasks that are heavily impacted by symptoms like fatigue, headaches, and a lack of sleep. And so it was definitely comforting to see that decrease throughout the weeks. We also looked at the symptoms, and we can see them listed here. The orange line, we'll start with the blue line is week 0 and the orange line is week 20. So before the program or at the start of the program and at the end of the program. And so here, for example, if we take sleep disturbance, 24, so almost each of the survivors shared experiencing sleep disturbance. And then at the end of the program, we had 23 survivors shared that they experienced sleep disturbance, so forth and so on. For seizure, we had 4 survivors shared that they experienced seizures at the start of the program. And then at the end of the program, 1 survivor shared that they were still experiencing seizures. And so across all of the symptoms and across the program, we saw an overall 19% decrease in the frequency of symptoms experienced by our survivors. And we also asked about the severity of these symptoms and saw that there was a 13% decrease in the severity of these symptoms. And so on average, these were symptoms that were between fair and very severe. And then by the end of the program, they were on the mildly severe to fair experience. We also asked folks about their knowledge and understanding of gender-based violence, as well as of brain injury. And what we saw was that the knowledge of gender-based violence, and so that's the green line here, was fairly good at the start of the program and still saw a 12% increase at the end of the program. That of brain injury at the beginning of the program in blue here was lower, but increased quite steeply by the end of the program. And in the pink is the coping strategies linked to brain injury and gender-based violence. And so knowledge is very good. We can see that gender-based violence, brain injury knowledge increased. But importantly, the coping strategies, which are important to know how to essentially adapt and deal with the experiences, the symptoms that we're having increased. And so that speaks to kind of the practicality of the program and how survivors were able to learn, for example, using glasses for screen fatigue and other tools that they could use to kind of deal with their experiences living at this intersection. The Adult Hope Scale was developed by psychologist C.R. Snyder in 1991, and it's a self-report measure to assess individuals' level of hope. It's based on hope theory, which defines hope as a combination of agency thinking, which is willpower, and pathways thinking, which is way power. And although this has been studied a lot in cancer research, less so in the gender-based violence sector, and there's definitely some controversy around its use and maybe its assessment and how it applies to different sectors. But we thought it would be a good opportunity to look at hope, nevertheless, in this specific program. And so, as mentioned, there's agency and then there's pathways. And the hope score, essentially an individual scores between 40 and 48. They're hopeful. 48 and 56, they're moderately hopeful. And then a high hope is 56 and above. And so overall, survivors remain hopeful across the program. So kind of taking these two numbers together, we see how they fall within these ranges. Um, but we saw an increase by the end of the program. Now, that being said, agency, which is willpower, decreased by 3%, and then pathways, which is way power, increased. And that was quite interesting for us to note, but it also really kind of gave us insight about what could be happening. And so that 3% decline in agency and willpower might be a depletion of motivation and energy to pursue goals. This could be attributed to like the emotional and psychological demands of engaging in deep healing. So we know that healing is work, right? And confronting trauma can reduce someone's sense of personal drive because of how effortful and how exhaustive it is. In contrast, we have pathways, which is way power, increasing by 7%. And that indicates that survivors became better at identifying the strategies, the coping mechanisms, the solutions, and the alternative approaches to navigate their challenges. And so we can think about this a little bit as like the growing pains of healing. But this was very interesting insight when looking at the hope score about how healing can be effortful yet rewarding. So we'll shift gears now to look at the qualitative findings of this program. So we had a focus group or interview depending on survivor preferences. And again, they could engage in this or not. And so we had 21 survivors engage in a focus group or interview. And we wanted to know, well, what did they enjoy about this 5-month program? What didn't they enjoy? Did it address their identity or in different ways? Did they learn anything? And what do they hope for when they think about the supports they're receiving? Like, what is their dream? And all in all, there were 4 main themes that came across that have passed positive and constructive feedback, as well as some key takeaways and hopes and aspirations. And so looking at positive feedback, typically there were quite a bit of positive sentiments that were self-reported across the various areas, including mental and physical health. To note at the donut here, these are sub-themes that came across. We identified 113 sub-themes, and so we're sharing here the top 5. And the numbers in here are the numbers of mention across the different focus groups and interviews. And so all in all, people really felt that the program was strength-based, it was judgment-free. They really loved the peer navigators, how trauma and violence informed it was, and the social location being addressed. And here I've pulled out some of the quotes that were shared by survivors. And I always like to add these to really contextualize, but also to hear survivors' voices and experiences. And so definitely give folks a little bit of time to read these through. But I can hone in on social location being addressed, for example, where CW shares, I like how this includes all women that are like myself with trauma and all these different types of issues that we've had. So I really appreciate the inclusivity and the respect I was given here. And I think that's quite powerful and speaks to how important it is to design programs with social location being addressed in mind, and that diverse and inclusivity approach, which is why being cross-sectoral is really key. Next, we had some constructive feedback as well. And kind of the 5 key areas was some survivors experienced a lack of connection. There were time constraints, which very popular when you have a funded program. There's only so much you can do with the budget that you have. But different parts of the journey came out. So that was essentially noting that other survivors were maybe, just leaving their situation, their violent situation, where others had left maybe years ago. And so those survivors being at different parts was a constructive feedback that we received. And then being triggered, as well as some miscommunication. And so here are a few examples of what that looks like. We have RE share, I just wish it was longer, that's all. And then AC shared that I realize what what I realized was that it was hard hearing other people's stories. And so keeping in mind this feedback, really honing in on how to best mitigate, hearing other people's lived experiences, knowing that it can be healing and it can be supportive to know that someone else has gone through what you've gone through, but also knowing that it's challenging and can be hard. And so having in place measures that can be supportive for an individual once they're there. We also had some key takeaways. And so this really encompasses the tangible takeaways that survivors obtained throughout the program. And so the survivors talked about what they learned and how they're going to use what they learned. And so here we had language being important, skill building, strategies and tools, how this was important for empowerment and the self-esteem and growth. And I really love the self-esteem and growth piece where Ari says, you guys make me feel that I have a voice and that I do matter. You guys gave me back myself, confidence, which I didn't have before. And so always heartwarming to kind of hear how a program and all of the effort that goes into being multidimensional, cross-sectoral, wraparound services can really change someone's experience in someone's life and really support self-esteem building, confidence building, and essentially empowering. And then the last thing, we have hopes and aspirations. And so really thinking beyond the program, thinking about sustainability, thinking about what's next and what's in the future. And here we really talk about community building and community supports, as well as having accessible and specialized programming with additional modalities. And so if we take community building here, TI says, I would love to see mentorship where we're able to train for similar roles or to volunteer in the program. And we thought that this was very key in that survivors want to be a part of the advocacy, and that's important, and that should be recognized, and that's where lived experience actually should be very valued and centered, which is what we aim to do at the organization. Knowing that lived experience should be recognized as expertise and highlighted as such, because survivors have a wealth of information to share. And thinking about community supports, CW shared having something structured that's goal-based about self-love, being authentic and true to yourself, healing and being listened to, all that in one package. Those are the ingredients in a recipe, and those things on my plate would be a nice meal. Really like the metaphor here about having a nice meal that has all of these ingredients. And so it speaks to how individualized these programs also need to be in a way, and having a lot of different options available so survivors can really pick off of, again, this buffet and create their perfect meal. And so with the few minutes that I have, I wanted to share the key learnings from this entire program and how that this can be adapted and this can be applied into older adulthood. And so one key learning was that of peer support and peer navigation, and making the distinction between the two. So peer support involves building a community of survivors to be amongst those who validate their lived experience and provide emotional safety. Peer navigation goes beyond in that it's offered by a trained peer support worker with the lived experience, but as well as unique systems navigation expertise. And so how to navigate homelessness, how to navigate poverty, how to navigate the courts, education, accessing financial stability. And supports. And so it really speaks to kind of those fundamental trauma and violence informed components to really ensure that survivors can report better mental and general health, improve coping and confidence, and then greater understanding of the brain injury symptoms and how it'll look like in adulthood. Another key learning was addressing the specific intersection of gender-based violence and brain injury and how these specific challenges arise and what to do with them, really. So we noted 91% of survivors reported their brain injury was sustained through GBV. And we noted, again, that many of that was through hits to the head, followed by strangulation, choking, and substance abuse. These have neurological impacts as well, as I had mentioned earlier. And so looking at, for example, what are the ramifications for pharmacological abuse, for substance abuse? What will that look like in older adults? What will that look like when thinking about medications? What will that look like in terms of the impacts on their blood pressure, cholesterol, so forth and so on, but also at the brain level when they go for their next MRI scan or their CAT scan, so forth and so on. And so all in all, we note that these are risks that are compounded by pre-existing health conditions, but they're also delayed diagnosis and misattribution to aging that can occur here as well that we need to look at. So the other side of things, noting that someone has experienced this, and maybe this is where their health challenges are stemming from, and not necessarily linked to aging, but instead linked to their experience of strangulation or choking or forced substance abuse. And so that education for providers on brain injury signs in older adults is one thing, but also distinguishing brain injury from cognitive aging or dementias is important. Next, we have structured closure for survivors. And so this is very important because we noted how it's important to be intentional, careful, and transparent with regards to session closure, not only for survivors, but for staff as well, because abrupt endings can leave one feeling abandoned and could essentially compound kind of the effects of existing trauma. What we saw in the data was that between the weeks, we observed a notable improvements in health and symptom relief, with the most significant progress occurring at week 16. But by week 20, these improvements went down a bit and stabilized rather than rise. And that suggested that the impending conclusion of the program was impacting survivors' well-being. And so ensuring that there's supportive closure of programs, a structured debrief, there's continued access to resources, transparent communication, and pathways to peer support is really important. And this is also where we get to address sustainability and long-term planning and program design. This anticipation of closure really contributes to emotional distress and uncertainty, as well as fears of losing community and structure, which becomes integral to the healing journey. And so we recognize that structure for closure is important, and also for staff because it plays a vital role in how they deliver peer support, but it also plays a vital role in making sure that they don't experience vicarious trauma. And so having reflective supervision, mental health check-ins, and debriefing as well helps to prevent overall burnout and compassion fatigue. And so when we think about older adults, we think about their caregivers as well, and support persons, and how a closure of a program, even though that program might only be for the older adult, how that should take into consideration the caregiver or the support individual. So that, that closure helps to kind of cushion the loss of some of the services that might occur. So here, a powerful quote from CW saying, "I'm sad when I have to end because when will I be heard again? I don't want to be left on my own again." And so really speaking to how crucial it is to think about how programs end and how folks still have access to all of the supports and services that they've been exposed to. Next, we have language and cultural barriers, which I spoke to earlier as well. And this is important because we need to think about language and cultural barriers, how they present challenges for marginalized communities, but also how language matters not only in terms of definitions and translations, but how it matters in terms of interaction, social interaction, and cultural nuances and interactions and the barriers that could be presented. And so it's not just a matter of translating materials, which we learned throughout the program, but it's really a matter of comprehensive interpretation. So, for example, in our program, that would have meant having French-speaking peer navigators and facilitators and supports. Having representation in terms of the individuals that deliver the services. And so we know that research indicates how social engagement and activity are protective against cognitive decline and also protective against slowing the progression of Alzheimer's and other forms of dementia, and forming these strong social ties between participants and also ensuring active participation are all social activities that can improve cognitive function by stimulating attention, stimulating memory, improving mood, and emotion. And so those are the symptoms that I mentioned at the beginning of this presentation, and we can see how essentially language and cultural barriers, once removed, can really support the kind of healing journey in terms of attention, memory, and the brain networks that are stimulated through social engagement. Number 5 is my favorite. And once it came out through survivors kind of sharing their experiences, it was like an aha, like this is so obvious to me, but it's the need for joy-based healing spaces. And so survivors noted the importance of moments of levity and connection, like reinforcing this need for integrate creative expression and social activities and informal peer engagement to ensure that we were celebrating and honoring resilience, progress, and personal victories. And that's important because healing is not only about the trauma and it's not only about the work, but it's about reclaiming joy and agency in everyday life. And so when I was talking about hope, I alluded to this a bit, but essentially we know that healing is work, not only in terms of social interactions, but it's work when you even think about it at a physical level, right? Think about having like a wound and like what your cells and your body needs to do to heal that wound. It's effortful, it's exhaustive. And so ensuring that you have moments of joy, moments of celebration, moments of reclaiming is really important. And so we had music therapy as a service that was offered and really supported in celebrating. And so CA shared the music really got people to work creatively and brought a humor into it, or brought a sort of levity. And so ensuring that programs have joy, honestly might be like the next phase of my life. But I think that was just like a wonderful area that also needs to be more researched and integrated in the programs that we have on a day-to-day basis and at the community level. And then lastly, which thankfully I'm on time, lastly, we have survivor-centered preferences and flexibility. So one of the key tensions in survivor-centered programming is balancing inclusivity with the need for personalized, tailored support. And this pilot program really highlighted that need for flexibility and ensuring that preferences as well as access to diverse modalities were met. And so having individualized accommodations and diverse outreach strategies are all key. And offering the variety and the choice is essential for providing agency and autonomy, both of which are severely infringed upon in gender-based violence as well as in aging. And so we've, I think, mentioned in previous presentations this loss of agency and autonomy, and ensuring that services are flexible and individualized help reclaim that. And so recognizing that preferences and accessibility needs of survivors should shape future program design, ensure that the offerings align with participants' priorities. And so it really ensures that survivors with varying needs can participate meaningfully. And for example, we use a hybrid approach as much as we could. Even though we operate remotely, there was an opportunity to meet in person. As mentioned, we had different services just to see what folks, want to gravitate to and want to engage in to heal. really the survivors emphasize the importance of choice, how their engagement levels and the need for facilitators validated the diverse pathways to recovery. And so even if survivors or participants don't engage in all that you're offering, just having them available is important because it really reinforces the building or rebuilding in some cases of their agency and their autonomy. And so with that, I bring my presentation to an end, and thank you folks very much. And if there are any questions, I'll be happy to answer them.
Thank you so much, Dr. Gifty Asare. It was excellent. Such an excellent overview. I think sometimes we don't think about, brain injury in regards to seniors, particularly. We may think it as an aging problem, as you had referenced. And, this seems like a really great program that we could potentially adapt into other communities, especially I think with the messaging, what you were saying around, the creative solutions and the collaborative integration of services, a wraparound approach, similar to what Alberta had just been speaking to as well, that we have to work together and provide that support. And I think sometimes it just gets, as an older adult, we may misdiagnose it, I think, as you indicated as well. We may not ask the questions. Someone goes into an emergency or healthcare, and maybe that's not even on people's radar. And I know that the Canadian Network for the Prevention of Elder Abuse is looking at developing some tools to educate service providers around gender-based violence and making them more aware to ask some of these questions when they are presented with an older adult that might be experiencing some of the trauma. So I do appreciate all of your work, and I'm hoping that other people will adapt this and take this to the next level. I was already looking at your website and just intrigued by all the resources that you have on file that people can download and have accessible to them. So I'm not sure if there's any other questions that has come up. But if they do, then if you're sticking around for a little bit, then we can maybe pose that. But thank you so much again. And I see Benedict online now.
Well, I guess I have a question, and it might have been because I missed it during the presentation, but you mentioned in the age breakdown that you did have a few participants that were in their late 40s, late 50s, and early 60s. Was ageism or anything related to their experience as a person who is older either mentioned any way or addressed in any way? Was that something that, I know it was not necessarily the main focus, but was that part of the conversation in any way?
That's a very good question. And thinking, I wouldn't say specifically, we definitely had a few opportunities for conversation around ageism. And what we noted was that kind of came through when survivors were mentioning the different parts of their healing journey. And so I know I shared that as one of the feedbacks that we'd received. And so I want to say that's how that came across, where there are some survivors that had left, their situations years ago. And then there are those that had left it maybe a few months before the program had begun. And so we can really see how they would have different needs and how those would need to be addressed differently. And the other thing that actually came up was, and it's not funny, but it's just how the survivor had worded it always kind of makes me laugh. But essentially, there were survivors that had children, had young children, and talked about maybe how to best support their kids and wanted maybe more parenting kind of guidance and support. And there were those that didn't. And so there was definitely mention of we're always talking about kids and I just don't want to talk about kids anymore. And so that was very interesting when you saw that come across, because that really also kind of speaks to, different needs being at different stages of the lifespan, but not specific to aging, as you might be alluding to, but definitely worth looking into in the future.
Thank you so much for this. I'm just monitoring the Q&A just to see. I think people are still digesting. It was a fantastic presentation. I learned so much. You have no idea. And I think we're getting a lot of really positive comments in the chat box. I think that really hit home. I know that the part about joy-based healing really also hit home for me, because that's something that I think we've encountered, Ryan and I, in various conversations around aging and preventing abuse or well-being, whether it's in long-term care or in the community, where we talk about all the other things, all the bigger, important, very important things. But sometimes the component of joy and enjoyment sometimes gets dropped, and that can play such an important role in how someone, in terms of prevention factors, as well as healing and recovery and resilience. So thank you for highlighting that. That was really great.
Thank you so much.
I don't really want to cut this short because I feel like there's so much to be said, but I also want to give people another few minutes to take a breather because we've been at it for a few hours now. So, Gifty, Dr. Asare, thank you so much for being with us today. I really appreciate it.